So, as you know, vestibulocochlear nerve is a sensory nerve. It is a purely sensory nerve. It has two components. One is vestibular component and another is cochlear component, and we are done with the cochlear component. And today we will discuss the vestibular system. Okay. So, may I ask you what do you mean by vestibular system? What do you mean by vestibular system? Or a system which deals with your balance, okay, whenever you are walking or riding something, right. So, it is a system in your body which deals with your balance. So, what do you know about balance? What are the body parts or what are the neuronal component that deals with your balance? Anyone? Anything in the body that deals with your balance? Yes? Vestibulocerebrum, cerebellum. Okay, okay. So, it is a part of cerebellum that deals with your balance, vestibulocerebellum. Okay, that's correct. Anything else that deals with your balance? So, there are multiple systems in our body that deals with our balance. So, one component is definitely your cerebellum. Your cerebellum deals with your balance. Okay. Anything else? Yes? Inner ear. Yes, very nice. Inner ear. So, inner ear. Within the inner ear, we have the cochlea and the vestibular component. Okay, that also deals with your balance. Anything else? Anything else? Any sensory tract like that? Any sensory tract that deals with your balance? Any sensory tract? Yes, dorsal column pathway. Very nice, very nice. It is the dorsal column pathway that deals with your balance. Okay, that senses your proprioception. Okay, or joint position sense. So, yes, your knowledge is quite clear. So, there are multiple systems in our body that deals with your balance. Number one, your cerebellum. Number two, the inner ear, the vestibular part of your inner ear, and also the posterior column, right, or the dorsal column that deals with your balance. Okay, so let us today we will start vestibular system with a clinical case, right. So, it is a clinical case. So, the chief complaint of the patient is difficulty in moving the eyes and double vision for 3 days. Okay, কোন এক পেশেন্টের 3 দিন ধরে ডাবল ভিশন হচ্ছে, মানে একটা জিনিসকে দুটো জিনিস দেখতে পাচ্ছে, রাইট। ওকে, ডাবল ভিশন হচ্ছে। হোয়াট ইজ দ্য হিস্ট্রি অফ present illness? So, the 32-year-old woman presents with complaints of horizontal diplopia, double vision, especially when looking at left. পেশেন্ট যখন বাঁ দিকে তাকাচ্ছে তখন প্রত্যেকটা জিনিসকে ডাবল ডাবল দেখছে, রাইট। ওকে, and she reports occasional dizziness but no limb weakness, no history of trauma. She recalls several episodes of blurred vision and tingling in her legs over past year, which resolved spontaneously. Okay, so there is a specific complaint when the patient is looking towards left, there is double vision. Okay, otherwise it is okay when the patient is looking straight, when the patient is looking towards the right, there is no problem. But when the patient is particularly looking towards left, okay, when the patient is looking towards left, so this is my left, right. So, when the patient is looking towards left, there is double vision. একটা জিনিসকে দুটো দেখছে, right? So, this is the problem. Okay. Now, in past medical history, no known chronic illness, no hypertension or diabetes on examination, right? Findings on cranial nerves on left gaze, the right eye fails to adapt past midline. So, just imagine what will happen if I, assume myself as a patient, this is my left side and this is my right side, okay? So, myself is a patient, and when I am trying to, the same patient, when I am trying to look at left, what will happen? My left eye, this is my left eye, so my left eye will abduct, correct? And the nerve is, which muscle and which nerve? My left eye will looking at this side, matlab my left eye will abduct, okay? So, the nerve involved and the muscle involved. Yes, lateral rectus. For my left eye, it is lateral rectus, which is supplied by cranial nerve 6. Very nice. Okay. So, similarly, when I am looking at my left, okay, my left eye abducts and my right eye adducts. Okay. So, right eye moves medially and left eye moves laterally. Okay. So, for left eye, it is the abducent nerve and lateral rectus, and for my right eye, it is the medial rectus. And the nerve is oculomotor nerve, cranial nerve 3. Okay, so this is called conjugate eye movement. Okay, This is called conjugate eye movement. When I am looking at a particular side, okay, so one eye will abduct and another eye will adduct, so that both the eyes will look towards the left, right? Okay, this is called conjugate eye movement. For one eye it is the abducens nerve, and for another eye it is the oculomotor nerve. So both the nerves are working simultaneously. Okay, this is called conjugate eye movement, and in this patient, in this particular patient, the conjugate eye movement is lost, right? So what is happening in this patient? So for left eye, abduction is okay in this patient, but for right eye, adduction is not happening. It is not crossing beyond the midline, right? It is not crossing beyond the midline. Okay, so abduction is okay for left eye, but adduction is disturbed in the right eye. Okay, this is what happening. Okay, so this is why the patient is having double vision sensation. Okay, আমি যখন এদিকে তাকাবো আমার দুটো চোখই তো এদিকে মুভ হবে, কিন্তু পেশেন্টের লেফট আই মুভ হচ্ছে, রাইট আই মুভ হচ্ছে না, right? This is the problem. Okay, getting the problem? Okay. So other examination, cerebellar sign negative, reflexes are normal, motor sensory no weakness or no sensory loss. Okay. Now I'll later on come to the diagnosis, and after this class, finally I will come again to this case. Okay. So the patient has undergone an MRI, and MRI reads that plaques in the periventricular white matter and right MLF region, suggestive of multiple sclerosis. Okay. Anyway, I am coming to the diagnosis later on, because first you need to understand what is happening to this patient, right? So again, as I told that, now onwards I will teach you in question and answer fashion. So entering into vestibular system, and once the vestibular system is over, I will again come back to this case, right? Once the vestibular system physiology is over, I will again come back to this case and explain what is happening to the patient, okay, and what is the diagnosis and what is happening to the patient. Okay, so vestibular system, which deals with your balance. We have some peripheral vestibular component, and we have some central vestibular component. Okay, peripheral vestibular component and central vestibular component, right? So peripheral vestibular component, it is totally your inner ear, which has 3 semicircular canals. Okay, 3 semicircular canals and 2 otolith organs. These otolith organs, oto means related to ear and lith means stone, right? Okay, so 2 otolith organ, these organs are called saccule and utricle. Okay, saccule and utricle, and the central component is the vestibular nucleus in the brainstem. Okay, vestibular nucleus in the brainstem, the cerebellum, you have already told, cerebellum is a part of vestibular system. Okay, vestibular spinal tract and vestibular ocular reflex and vestibular spinal reflex, these are the central components. Okay, so this all together forms your vestibular system, the peripheral vestibular system and the central vestibular system. Okay, now we are here to deal with the peripheral vestibular system, that is within our inner ear. Okay, so first let us see the semicircular canals. What are semicircular canals? So you know there are 3 semicircular canals in your inner ear, and those semicircular canals are anterior, posterior and lateral, right? Anterior, posterior and lateral, and each semicircular canals are oriented at an angle of 90 degree, right? So just in a 3-dimensional axis, one is in the x-axis, another is in the y-axis, another is in the z-axis, right? So 3 semicircular canal SCC, they are oriented in a vertical fashion. Okay, anterior, posterior and lateral, and each are sensitive to rotation. Okay, each are sensitive to rotation at a particular plane, rotation at a particular plane. Okay, vertical plane, horizontal plane and another vertical plane, right? And the base of the semicircular canal is called the ampulla, right? And it is the enlarged base of the semicircular canal. Okay, and within this semicircular canal we have crista ampullaris, and crista contains cupula, one gelatinous structure, right? So you see this here, and this cupula contains lots of hair cells, just like hair cells in the cochlea. You have known the structure of hair cells. Hair cells have got multiple cilia, and the cilia are of different length, right? Shorter cilia and taller cilia, right? So the hair cells are embedded within the cupula, right? once your head rotates, right? So many times our head rotates during riding a merry-go-round or something like that. You are riding some water game or like that, right? So it may happens many times during our day-to-day life. Our head rotates, okay, and semicircular canals are there to sense your rotational acceleration. As because these three semicircular canals are oriented in 90-degree fashion, okay, so they can detect rotation in respect to all three axes, okay, they can detect rotation in all three axes, right? So what is the basis of this sensing rotation sensation? So once our head rotates, endolymph, it lags behind due to inertia. Okay, endolymph is there within the semicircular canal, right? Within the semicircular canal, there is a liquid called endolymph, the same endolymph that is there in this chlamydia. Okay. So due to inertia, endolymph lags behind. Okay, endolymph lags behind, and as the result, there is bowing of the cilia of the hair cell, right? So once bending towards the kinocilium, it has got one kinocilium and all other the stereocilia, right? So once there is bending towards kinocilium, there is depolarization, and bending away from the kinocilium is hyperpolarization. And once there is depolarization in the hair cell, again there will be a formation of action potential in the vestibular nerve. Okay, so very simple. Just remember this thing, not going into much details about this. So you have three semicircular canals. আমাদের তিনটে semicircular canal আছে. Semicircular canalের যে বেসটা সেটাকে আমরা বলছি অ্যাম্পলা। অ্যাম্পলার মধ্যে একটা জিলাটিনাস ম্যাটেরিয়াল আছে যেটাকে আমরা বলছি কিপুলা, তার মধ্যে হেয়ার সেলগুলো এমবেডেড আছে। তো এখানে হেয়ার সেলগুলো ককলিয়ার হেয়ার সেলের থেকে একটু পার্থক্য আছে, এখানে একটা কাইনোসিলিয়া আছে আর বাকিগুলো সব স্টিরিওসিলিয়া আছে। ঠিক আছে, তাহলে যখন হেড রোটেট করে, আমাদের হেড যখন রোটেট করে তখন কি হয়, এন্ডোলিম্ফ ল্যাগস বিহাইন্ড ডিউ টু ইনার্শিয়া। ওকে, আর সেটার জন্য কি হয়, সিলিয়াগুলোর মুভমেন্ট হয়। ওকে, বাকি সিলিয়াগুলো কাইনোসিলিয়ামের দিকে যদি মুভমেন্ট হয়, then there is depolarization in the hair cell and formation of action potential in the vestibular nerve, right? Okay, so this is how it happens. When once there is head rotation, this is one semicircular canal and you see the hair cells over here. Okay, once bending towards the kinocilium, there is depolarization. Okay, very simple. That is what you need to remember. No long question from vestibular system. Okay, now the otolith organ. Other than semicircular canal, in the vestibular system, you have saccule and utricle, two otolith organ. Why otolith? Because it contains stone. What stone? Calcium carbonate stone. Okay, calcium carbonate stone, right? So both saccule and utricle contains macula, a patch of hair cell embedded in the gelatinous otolithic membrane, topped with otoconia. Otoconia is calcium carbonate crystal. Okay, otoconia is calcium carbonate crystal. এই ক্যালসিয়াম কার্বনেট ক্রিস্টালগুলো অনেক সময় ডিসলজ হয়ে সেমিসার্কুলার ক্যানালের মধ্যে চলে আসে। ঠিক আছে, এই ক্যালসিয়াম কার্বনেট ক্রিস্টালগুলো ডিসলজ হয়ে সেমিসার্কুলার ক্যানালের মধ্যে চলে আসে। তখন কি হয়, you will face many patients if you are sitting in ENT OPD or even general medicine OPD, you will see many patients, they will be complaining of reeling of head, মাথা ঘুরছে। ঠিক আছে, okay, they will be complaining of reeling of head. We call it vertigo. Okay, what type of vertigo is this? Benign paroxysmal positional vertigo. Okay, once these calcium carbonate crystals are dislodged from the saccule utricle and they enters into semicircular canal, right? Okay, so both saccule and utricle contains macula, they contain calcium carbonate crystal, and the difference between semicircular canal and utricle saccule is that your semicircular canal detects rotational acceleration, okay, and utricle and saccule detects linear acceleration. Okay, linear acceleration. How to remember? How do you say yes? How do you say yes? Yes. Okay, how do you say no? Right? So saccule, S for yes. Okay, so remember in this way, because this is also an MCQ zone for your postgraduate entrance examination. So utricle is no, saccule is yes. Okay, utricle is no, saccule is yes. Saccule, S for S, right? Saccule for yes. Okay, so saccule is for vertical acceleration and utricle is for horizontal acceleration. Okay, horizontal acceleration means once you are traveling in a car. Okay, once you are traveling in a car, if you close your eyes, you can still say that I am in a car, it is moving. Okay, you can say that because you have the utricle. Okay, and once you are in an elevator, in a lift, right? Once you are in an elevator, in a lift, if you close your eyes, still you can say that I am in a lift. This vertical acceleration you can sense because of your saccule. Clear? Okay. So, function of semicircular canal, function of utricle and function of saccule, that is very important, also an MCQ zone. Okay. So, semicircular canal is for rotational acceleration, saccule is for vertical acceleration and utricle is for horizontal acceleration. Okay, that you have to remember, must. Okay. Okay. So, these are the orientation of hair cells. Hair cells are also there in saccule and utricle. Okay. So, in saccule the hair cells are oriented inside outwards towards the outwards, that is hair cells are oriented outwards. Okay. And in utricle the hair cells are oriented centrally, their cilia are oriented at the center, right. Okay. Now, coming to vestibular pathway, just like cochlear pathway, we have told how auditory nerve, once action potential is generated within the auditory nerve, how it is going to your auditory cortex and give you the sensation of a sound, right. Similarly, your balance or your position of head is also a sensation. It is carried through vestibular nerve and it goes to ultimately goes to cortex. But what are the steps? So, vestibular apparatus means your semicircular canal and saccule utricle. From vestibular apparatus, the nerve which generates is the vestibular component of 8th nerve. Okay. So, vestibular component of 8th nerve, it goes to vestibular nuclei in the brainstem, and the vestibular nuclei has 4 different parts, superior, lateral, inferior and medial. We call it SLEEM. Okay. So, superior, lateral, inferior and medial, and from vestibular nuclei you have 4 major output. One is medial longitudinal fasciculus to the motor nuclei. Okay. It controls the vestibulo-ocular reflex. I am coming to it. Okay. Then the vestibulospinal tract, then cerebellum and thalamus and cortex. Okay. So, see this picture. Okay. So, from saccule and utricle you get this vestibulocochlear nerve. This vestibulocochlear nerve goes into this part, it is the vestibular nuclei in the brainstem. Okay. From vestibular nuclei, fibers goes to cerebellum. From vestibular nuclei, it is the medial longitudinal fasciculus. Okay. So, medial longitudinal fasciculus, it goes to both 3, 4 and 6 nuclei. This part is related to the clinical case I was talking about at the beginning, right. So, from vestibular nuclei, fibers goes to both sides and it innervates 3rd, 4th and 6th cranial nerve. Okay. So, vestibular nuclei is also connected to 3, 4, 6 cranial nerve on both the side via a specific pathway that is called medial longitudinal fibers or fasciculus, medial longitudinal fasciculus, MLF. Okay. And MLF is a very important structure, and here I am telling you that the case which I was talking about at the beginning, the patient had damaged medial longitudinal fibers or fasciculus. That is why the patient was having diplopia. Okay. Okay, again I will come to the case. So, what you need to know that vestibular nerve once generated from semicircular canal, utricle, saccule, okay, they directly enters into vestibular nuclei which is in the brainstem. Now, from brainstem there are 4 pathways. One pathway it goes to cerebellum, and another major pathway is through medial longitudinal fasciculus that innervates both sides 3, 4, 6 cranial nerve, and there is another pathway that is vestibulospinal tract. Okay. There are anterior and lateral vestibulospinal tract. Okay. Okay. Now, few clinical things. What is benign paroxysmal positional vertigo? BPPV. So, it is a very frequent case. Once you see in ENT OPD or in general medicine OPD, you will see many patients, they are coming to you with this complaint. What is the complaint? Reeling of head, okay, matha ghurche, right, okay. So there is a specific maneuver as well, and that maneuver is called Epley's maneuver, where the patient lies down and do some, the patient does some maneuver by which the stone, which has been dislodged from saccule utricle to the semicircular canal, and it can get back into the saccule and utricle, right. So ENT surgeons usually does that and explain the patient how to do the training at home as well, okay. And we also give some medication, anti-allergics medication for treatment of this disease, right. So what is BPPV? The otoconia or the calcium carbonate crystal, they are dislodged from the saccule utricle to the semicircular canal, okay. And there is a specific maneuver called Epley's maneuver by which the crystal can be lodged back into the saccule and utricle, okay. And once it is done, the patient easily feels the relief, right. There is no reeling of head. Now Meniere's disease, what is Meniere's disease? Meniere's disease is excess endolymph that causes vertigo, tinnitus, ringing in the ear and hearing loss. Okay, now coming to the case. So this pathway is important for you, right. So here is the vestibular nuclei, right. So horizontal semicircular canal, this is the ampulla, and the vestibular nerve, it goes to vestibular nuclei, right. It goes to vestibular nuclei. This is, here is the vestibular nuclei in the brainstem, and from vestibular nuclei, fibers enters both side PPRF, which is called the paramedian pontine reticular formation, okay. So PPRF and MLF, these are two structures, okay, these are two structures in your brain. But remember, মানে the thing is, খুব সহজ কথায় বলতে গেলে, আমার রাইট ইয়ার থেকে ভেস্টিবুলার নার্ভ রাইট লেফট দুদিকের পিপিআরএফেই যাবে, ঠিক আছে। সো সি দিস, সো দিস ইজ ফ্রম ওয়ান ইয়ার, ভেস্টিবুলার নার্ভ ইজ এন্টারিং ইনটু ভেস্টিবুলার নিউক্লিয়াস on this side, okay, vestibular nerve on this vestibular nuclei on this side, but it is moving to PPRF on both the sides, right. It is moving to PPRF on both the sides. Now medial longitudinal fiber, medial longitudinal fasciculus, this MLF, see this medial longitudinal fasciculus, it crosses to the opposite side, okay, it crosses to the opposite side and innervates the third nerve nuclei. So MLF is basically a connection between এক-সাইডের abducent nerve আর অন্য দিকের oculomotor nerve nucleus, okay. So MLF is a connection between 6th nerve nuclei and 3rd nerve nuclei, but of opposite side, ठीक है. MLF is such an important structure, right. So it connects 6th cranial nerve nuclei and 3rd cranial nerve nuclei, but of opposite side, okay. And this is the function of your medial longitudinal fiber that causes successful conjugate movement, okay. একদম প্রথমে আমি যে এক্সাম্পলটা দিয়েছিলাম মনে আছে, the patient had the problem, right. So once I am looking towards my left, okay, once I am looking towards my left eye is getting abducted, so lateral rectus, right, and my right eye is moving medially, that is third nucleus. So there must be a connection between একটা সাইডের 6th nerve nuclei and opposite সাইডের 3rd nerve nuclei, and that connection is medial longitudinal fiber. And in our case, the patient had a defect or damage in the medial longitudinal fiber due to some disease process, due to stroke or hemorrhage or whatever, okay. So that is why the patient had diplopia while looking towards a particular site, clear. Okay, now this thing is called internuclear ophthalmoplegia. You will also study internuclear ophthalmoplegia in your ophthalmology in final year, or maybe in 3rd professional MBBS part 1, okay. So what is internuclear ophthalmoplegia? Internuclear ophthalmoplegia, it is a disorder of horizontal eye movement caused by a lesion in the medial longitudinal fasciculus in the brainstem, okay. What happens in medial longitudinal, what happens in INO or internuclear ophthalmoplegia? The medial longitudinal fasciculus, it connects the abducent nucleus, that is the 6th cranial nerve, on one side to the oculomotor nucleus of the opposite side, ওকে, একদিকের 6 নার্ভ নিউক্লিয়াসের সঙ্গে অপর উল্টো দিকের 3rd নার্ভ নিউক্লিয়াসের কানেকশন সিম্পলি। ওকে, so that your medial rectus movement, your lateral rectus movement is connected to medial rectus movement. ঠিক আছে, বোঝা গেছে তো? Everyone clear? Okay, so what happens in INO or internuclear ophthalmoplegia? The medial longitudinal fasciculus, it connects 6 nerve nuclei on one side to the 3rd nerve nuclei on the opposite side, and this connection is essential for coordinated conjugated horizontal eye movement, right? Okay, you see here the patient is trying to look towards the left. Okay, you can assume it with your eyes. Okay, so this is your left eye, this is your right eye, right? You can assume this picture with your eyes. So once you try to look towards left, that is left gaze. Okay, so this is 6th cranial nerve, this will be working, and this is your lateral rectus, right? And it is also connected to 3rd nerve nucleus in the brainstem, which is connected to the medial rectus of right eye, right? Okay, and this, once this medial longitudinal fiber is damaged, this adduction will not be happening. Okay, so this is the medial longitudinal fiber of the right side. So once the right side medial longitudinal fiber is affected, once the right side, understand this very carefully. So when the right side MLF is affected, abduction of right eye will be affected. যেদিকের MLF affected হবে সেদিকের adduction affected হবে, right? And abduction will be normal, but it will be associated with nystagmus. ठीक है? Clear everyone? Now again come to the case so that you can get the details. So here the you have done MRI and plex in paraventricular white matter and right MLF region. Okay, so right MLF region is affected. The disease is multiple sclerosis. Anyway, you don't need to know what is multiple sclerosis right now. Just remember MLF or medial longitudinal fiber fasciculus is affected in this case, right? Okay, and you come to the diagnosis. It is an internuclear ophthalmoplegia secondary to multiple sclerosis. It may be due to multiple sclerosis, it may be due to hemorrhage or tumor or anything that affects the medial longitudinal fasciculus, right? Okay, so the key points to remember is, once there is MLF affected, eye on the side of the lesion cannot adapt and contralateral eye abducts successfully but with nystagmus, right? যেদিকে MLF affected হবে সেদিকে adduction problem হবে. Okay, okay. Now এবার auditory part is over, vestibular part is also over, right? Now we will sleep. আমরা এবার ঘুমাবো, right? Brain electrical activity, right? We have already discussed. Okay, কি ওয়েভ আমরা ডিসকাস করেছিলাম? আলফা ওয়েভ, বিটা ওয়েভ, থিটা ওয়েভ এন্ড ডেল্টা ওয়েভ, ঠিক আছে? নাও রাইট নাও উই আর আমরা কি করছি এখন? ঘুমাচ্ছি না ডেফিনেটলি। ওকে, রাইট নাও উই আর attending classes, right? We are focusing on the physiology of sleep. Okay, how do people sleep? কি করে ঘুমায়? Okay, so alpha wave, beta wave. তো এখন আমরা একটা পার্টিকুলার টপিকের উপর কনসেন্ট্রেট করছি, রাইট? তো সবার কি ওয়েভ চলছে? ইয়েস, ভেরি নাইস। তাহলে আমাদের এখন সবার বিটা ওয়েভ চলছে। ওকে, নাও আমি যদি সব ভাবনা চিন্তা বন্ধ করে দিই and I sit relaxed. Okay, I sit relaxed or I sleep or I lie down relaxed but not sleeping, eyes closed. What wave will be there? Alpha wave. Very nice. তাহলে আমি কিছুই ভাবছি না, জাস্ট পড়ে আছি, চোখ বন্ধ আছে, তাহলে আলফা ওয়েভ। আর যদি কোনো পার্টিকুলার টপিকের উপর কনসেন্ট্রেট করছি, জেগে আছি, তাহলে বিটা ওয়েভ। ঠিক আছে? আচ্ছা, এবার লাইট স্লিপ। ওকে, হালকা ঘুমোচ্ছি, তাহলে কোন ওয়েভ? এগুলো সব এমসিকিউ, প্রত্যেকটা এমসিকিউ। কি ওয়েভ এটা তাহলে? লাইট স্লিপ থিটা, অ্যান্ড ডি ফর ডিপ স্লিপ ইজ ডেল্টা। ঠিক আছে? গভীর ঘুমোচ্ছে, মানে কোনোভাবে ডাকলেও উঠবে না আর কি। ঠিক আছে? ডিপ স্লিপ ডেল্টা। তাহলে এইটুকু মনে রাখতেই হবে। ঠিক আছে? আলফা ওয়েভ, বিটা ওয়েভ, থিটা ওয়েভ অ্যান্ড ডেল্টা ওয়েভ, এগুলো আমরা ইইজি যখন ডিসকাস করেছি তখন বলেছি, রাইট? আচ্ছা, নাও হোয়াট আর দ্য স্টেজেস অফ স্লিপ? Very important, listen it very carefully because every line, every sentence I tell is an MCQ. Okay, every line, every sentence. Take a sleep physiology is so much important, right? Every line is an MCQ. Okay, So sleep has got two stages. One is NREM, that is non-rapid eye movement sleep, and another is REM, that is rapid eye movement sleep. NREM sleep and REM sleep. Okay. Tale one night if you sleep one night, there are 4 to 6 cycles. ঠিক আছে, প্রত্যেকটা সাইকেলের মধ্যে NREM আছে REM আছে, রাইট? If I sleep whole night 8 hours 6 hours যাই হোক যার যেরকম, ঠিক আছে, তাহলে in an one night sleep I have to pass 4 to 6 cycle, কারো 4টে সাইকেল, কারো 5টা সাইকেল, কারো 6টা সাইকেল, এনিওয়ে, ঠিক আছে। প্রত্যেকটা সাইকেলের মধ্যে NREM স্লিপ আছে আর REM স্লিপ আছে, রাইট? NREM means non rapid eye movement, REM means rapid eye movement, ঠিক আছে, ওকে। প্রত্যেকটা সাইকেলের ডিউরেশন হচ্ছে 90 মিনিটস, ওকে। এভরি সাইকেল ডিউরেশন ইজ অ্যাভারেজ 90 মিনিটস, ঠিক আছে। সো 4 to 6 cycle in each night, 90 minutes per cycle, and duration of REM sleep gradually increases, okay. মানে during 5 o'clock AM, 5 AM or 4 AM or 6 AM, if I sleep from, say for example, from 10 AM to 6 AM or 11 AM to 6 AM, okay, sorry, 11 PM to 6 AM, okay, 11 PM to 6 AM, এই 7 hours যদি ঘুমাই তাহলে 90 মিনিটস 90 মিনিটস 90 মিনিটস এরকম করে 5টা সাইকেল হবে, ঠিক আছে। আর যত শেষের দিকে সাইকেলে যাবে তত REM স্লিপ বাড়তে থাকবে, okay. REM sleep is the most dangerous sleep where you dream about many things, okay. তো সেগুলো আস্তে আস্তে বাড়তে থাকবে, সেই জন্য ডিউরিং ডন পিরিয়ড 5 AM 4 AM এই সময় লোকে একটু স্বপ্ন দেখে, তাই তো, ওকে। আসছি, সো এই পুরো চারটা মনে রাখতে হবে, there is no way, you have to remember, right? So awake, okay. So once I am awake, এবার স্লিপ শুরু হচ্ছে কি করে? Once I am awake, I am having beta waves, right? Once I am awake, I am having beta waves, alert, mental concentration, eyes open হলে beta wave, আর eyes যদি closed হয় alpha wave, replaced by alpha wave. এবার স্লিপ শুরু হচ্ছে, রাইট? তো ফার্স্ট স্লিপ কি দিয়ে শুরু হবে, কোন স্টেজ দিয়ে শুরু হবে? NREM স্লিপ দিয়ে শুরু হবে, রাইট? So sleep will start with NREM, and NREM has got 1 to 3, NREM 1, NREM 2, NREM 3, right? NREM N1, N2, N3, right? So NREM 1, it constitutes the 5% of total NREM sleep, okay, 5% of the total cycle, right? So NREM N1, it is light sleep. So light sleep is definitely what wave? Theta wave, ঠিক আছে। তাহলে আমি জেগেছিলাম, একদম কনসেন্ট্রেট করছিলাম, বিটা ওয়েভ, তারপরে চোখ বন্ধ করলাম, কিছু ভাবছি না, আলফা ওয়েভ শুরু হলো, এবার ঘুম এসে গেল, রাইট? তাহলে কি ওয়েভ শুরু হলো? থিটা ওয়েভ শুরু হলো, রাইট? এবার থিটা ওয়েভ 5% থাকলো, তারপরে একটু ডিপার, ওকে, নট মাচ ডিপ, একটু ডিপার স্লিপে এন্টার করলাম, দ্যাট ইজ NREM স্টেজ N2, রাইট? NREM স্টেজ N2. So NREM, it is still theta wave, but there are specific things in the wave. We call it sleep spindle and K complex, and also there is bruxism. What is bruxism? Yes, very nice, very nice. Tooth grinding, okay, দাঁতে দাঁতে ঘষছে, ঠিক আছে। So tooth grinding. So MCQs will be formed in this way. So bruxism is found in, okay, very important MCQ. Bruxism is found in number 1 REM sleep, number 2 NREM N1, NREM N2, NREM N3. Tick, NREM N2. Okay, correct option is NREM N2. So remember, how to remember? Bruxism means tooth grinding, tooth for 2, NREM 2. Okay, so remember this, right? Stage 3, okay, stage 3 means NREM stage 3 means deep sleep, okay. NREM stage 3 means deep sleep. So definitely delta wave, okay. Delta wave কিরকম হয়? Delta wave, so this is delta wave, okay, high amplitude low frequency delta wave, high amplitude low frequency delta wave. So delta wave যখন N3 হয় তখন কি হয়, কি হতে পারে, সবার হয় না। So bed waiting, okay, bed waiting হতে পারে, okay, আর কি হতে পারে? sleep walking, these are not normal, okay. Bed waiting, sleep walking, and night terror, okay. There is a difference between nightmare and night terror, okay. Night terror means it's always negative, right? So getting frightened or something like that. Okay, but dream may be well pleasant, positive side, right? Okay. So bed waiting, it can happen in N3. Okay, sleepwalking, এটা চলে গেল ঘুমের মধ্যে, ঠিক আছে? এটা হতে পারে, আর কি হতে পারে? নাইট টেরার, ওকে, এটা হতে পারে। সো দিজ আর দ্য ফিচার্স অফ N3 sleep. Okay, again these are all MCQs. Night terror is seen in N1, N2, N3. Okay, then sleepwalking, it is called somnambulism. Sleepwalking, it is seen in N1, N2, N3 REM. So correct option you have to take, right? So all are MCQ. In this zone, all are MCQ, right? Bed waiting, it is seen in N1, N2, N3 REM, right? Okay. Okay, so how to remember N3? 3 means flee, pali jacche. Walking, sleepwalking. Okay, 3 means flee. 3 means TR, terror. Okay, 3 terror, right? Okay, so remember N3. Okay, তাহলে N2 তে কি হয়? Bruxism, tooth grinding. Okay, N3 তে কি হয়? Sleepwalking, bed waiting, bed waiting, PWP, right? So flee, P3. Okay, flee, P3. Bed waiting, night terror, sleepwalking, everything is N3. Okay. Now REM sleep. REM sleep is the last stage. It is 25%, but gradually, cycle by cycle, it will increase. Okay. In the first cycle, it will be 25%. Next cycle, it will be 30%. Next cycle, it will be 35%. So gradually, cycle by cycle, REM sleep increases and NREM sleep decreases. Okay. So during the time of your waking up, REM sleep will be maximum. REM sleep will be increased, right? So what are the features of REM sleep? REM sleep is characterized by loss of muscle tone, atonia. Okay. If you want to move, you will not be able to move. Okay. So complete loss of muscle tone. Have you experienced that? So at the many it's not very common, but it may be seen. Okay, loss of muscle tone will be there in REM sleep. Okay, maybe you are suddenly awakened, হঠাৎ করে জেগে গেলে, and you are trying to move your right arm and you cannot move because it is almost totally paralyzed. Okay, so loss of muscle tone, complete loss of muscle tone, right? Complete loss of muscle tone except two muscles, that is diaphragm and extraocular muscle. So you can move your eyeball. You can move your eyeball and you are able to breathe in and breathe out because your diaphragm is okay, right? Your diaphragm is okay, your extraocular muscle is okay. Okay. Even if you cannot turn to sides. Okay. Say for example, you are supine and you cannot turn, right? Yes. Okay. So what are the features of features are in REM sleep? Dreaming, very important part. Dreaming is seen in REM. Okay, dreaming, nightmares and penile erection. Okay, these are features of REM sleep. Okay, now again this part is important, again MCQ zone. So there are few substances or factors which affects your sleep pattern, right? So alcohol, benzodiazepines, barbiturates, these are drugs. They reduce N3 and REM sleep. N3 REM sleep দুটোকেই কমায়. Okay. So that is why benzodiazepines are useful for sleepwalking, night terror, right? So যে সমস্ত পেশেন্টদের sleepwalking, night terror এগুলো হয় তাদেরকে আমরা benzodiazepine বা barbiturate দিয়ে ট্রিট করে থাকি, right? These are medications for sleepwalking, যারা ঘুমের মধ্যে হেঁটে হেঁটে চলে যায়, ওকে, তো তাদেরকে barbiturates দিয়ে ট্রিট করা হয়, রাইট? সো কেন? কারণ barbiturates এই সমস্ত, but not use alcohol for that definitely, ঠিক আছে? So alcohol, benzodiazepine, barbiturates, they reduce N3 sleep and also reduce REM sleep. Now aging, okay, aging is characterized by reduced N3 and REM sleep, মানে deep sleep কমছে, REM sleep ও কমছে, right? Depression is characterized by reduced N3 and increased REM, right? And narcolepsy, it is also decreased REM latency. So first 3 points are very important: alcohol, benzodiazepine, barbiturate, aging and depression. Okay, okay. Parkinson's disease you have all gone through, but this is another sleep pattern change in Parkinson's disease. So what happens in Parkinson's disease? Loss of atonia. We have told that REM sleep is characterized by loss of muscle tone. Okay, REM sleep is characterized by loss of muscle tone, but this loss of muscle tone is lost, that means muscle tone is preserved. Okay, that means muscle tone is preserved. So what will happen? REM sleep, major feature of REM sleep is dreaming. Okay, we dream in REM sleep. আমরা স্বপ্ন দেখি কখন? REM sleep এর মধ্যে স্বপ্ন দেখি, তাই তো? Now Parkinson's এর পেশেন্টদের কি হচ্ছে? Loss of muscle tone যেটা হওয়ার কথা REM sleep এ, that is not happening. So muscle tone is preserved. তাহলে কি হবে? Whatever the patient is dreaming, the patient will act the same thing. ঠিক আছে? As because muscle tone is not lost. Okay. So what happens in REM sleep? If, say for example, you are in REM sleep and you are dreaming of dancing. Okay, you are dreaming of dancing. So a patient of Lewy body dementia or Parkinsonism, it may happen that muscle tone is not lost and the patient is dreaming of dancing. So the patient will dance. Okay, getting my point? So this is called enactment. So the patient will act what the patient is dreaming, right? Okay, and most commonly it is associated with Lewy body dementia and Parkinson's disease. Okay, এটা দেখা যাচ্ছে না ভালো করে. So let me tell. So the effect of brainstem and hypothalamus on your sleep pattern. Okay, effect of brainstem and hypothalamus on your sleep pattern. So two things to remember. Okay, from your brainstem there are few neurotransmitters that are secreted. One is norepinephrine and serotonin and acetylcholine. Okay, so major thing is you have to remember what are the effects of neurotransmitter like acetylcholine, GABA, serotonin, এগুলোর effect sleep এর উপর কি আছে, right? Okay, so once acetylcholine is low and norepinephrine and serotonin are high, it will cause waking. Okay, তার মানে ঘুম পাবে না, right? And once norepinephrine and serotonin is low and acetylcholine is high, the effect of acetylcholine is important because acetylcholine increases REM sleep. Okay, and decreased acetylcholine is associated with waking. Acetylcholine যদি কমে যায় তাহলে সেটা wakefulness হবে. Okay, মানে patient ঘুমোতে পারবে না সহজে, right? Okay, and once acetylcholine level is high, REM sleep will be increased. And what is happening at the level of hypothalamus? In hypothalamus, you know two neurotransmitter, one is histamine and another is GABA, right? High histamine and low GABA, they will cause waking or wakefulness, and high GABA and low histamine, they will induce REM sleep. Okay, there is no effect of GABA histamine on REM sleep. They have effect on NREM sleep, right? This chart is directly taken from Canals Physiology. You can see that. Circadian rhythm. So this is the last part I will teach. So circadian rhythm. What is circadian rhythm? Everyone knows it is a biological clock, right? It is a biological clock, right? So body's internal clock that follows a 24-hour cycle that regulates your sleep pattern, that regulates your hormone secretion, that regulates your wakefulness, digestion and other vital functions. Okay, it is a biological clock in 24 hours format. It regulates your hormonal secretion and sleep pattern as well. Okay, now everyone knows melatonin. Okay, melatonin is secreted from which gland? Pineal gland. Very nice. And melatonin is related to sleep. It can induce your sleep. Okay. Okay, very often we also prescribe melatonin for the patients of insomnia. যাদের ঘুম ভালো হয় না আমরা মাঝে মাঝে melatonin prescribe করি. Okay, when there is when there is contraindication for prescribing any sedative drug. Okay, যখন sedative drug এর প্রবলেম আছে, অনেক abusability হয়, ঠিক আছে, পেশেন্ট ছাড়তে চায় না, তারপর ছাড়লেও আবার ঘুম আসে না, ঠিক আছে, অনেক প্রবলেম আছে, তো many a times we use melatonin, we prescribe melatonin to the patient because melatonin induces sleep. Okay, so what happens when light falls on your retina? Okay, see this again, this picture has been directly taken from Canals Physiology, right? So when light falls on retina, so there is a tract called retinohypothalamic tract. Okay, RHT is retinohypothalamic tract. Okay, and SCN is suprachiasmatic nucleus. Okay, so normal secretion of melatonin from pineal gland. You see, from pineal gland melatonin is being secreted, but there is a signal. Okay, that signal is coming from the hypothalamus, and two important nuclei in the hypothalamus, the paraventricular nuclei and intermediolateral nuclei. These two nuclei are located in the thalamus, right, in the hypothalamus, sorry, in the hypothalamus, paraventricular nuclei and intermediolateral nuclei in the hypothalamus. They are connected to superior cervical ganglion and it stimulates pineal gland to secrete melatonin. But when light falls on retina, through retinohypothalamic tract, suprachiasmatic nucleus is activated, and suprachiasmatic nucleus, it inhibits paraventricular nuclei, okay, so that this cycle does not happen and melatonin is not secreted. So that means when light is falling on your retina, melatonin will not be secreted, okay, and you will not be able to sleep. When light falls on retina, you will not be able to sleep because of no melatonin secretion. Now, what is the role of melatonin in circadian rhythm? So, melatonin is a substance which is secreted from, formed from one amino acid, which is called serotonin, okay. So, serotonin, from serotonin to N-acetyl, you will also see it in your biochemistry, from serotonin to N-acetyl serotonin and from N-acetyl serotonin to melatonin. You see the level of serotonin is high during daytime, level of serotonin is high in daytime and level of melatonin is high during night time. This shaded area is night time and here is the graph shows the concentration of serotonin, N-acetylcysteine and melatonin, right. So, melatonin concentration is high during night time and serotonin concentration is high during daytime, okay. So, once serotonin is high, you will be able to maintain your wakefulness, right, and once melatonin concentration is high, you will feel sleepy, okay.